And we're going to get started as we should with having Elder Sequoia ground us in
Have
how
the
we
heating
should
pad on
move
in the
forward
heater.
today.
Okay, and someone had sent an email asking if I was able to join for the day, and I need to apologize and say that I do a meeting at 9:30 to 10:30, so my day is quite broken up. So I'm just going to do the opening here and then turn it back over to you after I'm completed. Oh, I didn't realize my. So I want to say Kayachtan. I welcome each and every one of you to the those that are in the lower mainland, the unceded Coast Salish territories of the Squamish Nation, Tsleil-Waututh, and Musqueam First Nations, and that I'm Sequoia and Wanik from the Squamish Nation. And I just wanted to share with you that you've come together for a really good reason, and that you need to have Unchomo and Squalwin, one heart and one mind as you work together today. And to be able to have Winox's respect to listen to the words that you're going to hear, take into your heart what's meant for you, set aside what you don't need today, and maybe bring it back another day. And to be able to keep it in your thought, be a witness to what you're going to be sharing today, and to be able to Chen Chen Stwite, my grandfather taught me this, Chen Chen Stwite, stand and work together to hold each other up, support one another, and help each other. And that's what you're doing today, is coming together and creating a network of people. You came together for a reason. And, you know, you'll be able to put faces to names and be able to draw on each other, hopefully, as you move forward in the good work that you do. I just wanted to share those few words because I was thinking about your day today, and that you need to know that everything is meant to be the way it's going to be, and that all of us, our ancestors, survived everything and we're creating a legend. My granny said that when I asked her, can you tell me a legend like it was a story? She said, you know, legends aren't Aesop's fables or Grimm's fairy tales. They're real people and real things that happened. It's a legend that's about real people. And today you're creating your legend with the gathering that you're having. And you'll be talking about it in future days. So always remember that, in the legacy of the footsteps that you leave behind for those who are following you in the present and future. So I just want to share those few words with you. And I'm going to do Sequoia. My ancestor had a song, Sequoia Slolum, Squal, Sequoia's song, Greeting of the Day. And it's a healing song that the elders fixed in the 1910, 1920s to share with people, to help you with your mental, emotional, physical, spiritual well-being. And while my grandfather also shared that everyone prays to a higher power, and the higher power is known by many names, and that we need to respect each other's ways and respect each other as human beings. And so I'm asking you to come together right now in Chomo and Squalwin, as we say in Squamish, and Hamalkamalum, they say Natsamat and Squalwin. And other nations have their word for that. And ask you to just put your hands open. Don't be like this or this or this, you know, because you're closing your energy and spirit off. And I want you to come together and just open yourselves and take a few breaths. Few breaths. And then open yourself for the energy from Creator and the ancestors and each other, because even though we're in a virtual circle, you should be able to feel each other's energy. And while I sing the song, I ask you to pray for all your family and friends. And then I'll do a prayer. And then I'll turn it back over to Terry and Jillian for the rest of the day. And I am going to see, I believe some of you probably this afternoon when we do the workshop with Jillian and Namaste. So thank you for letting me share this part of your day. Hoichacha, thank you. I'm going to ask us to come together in Chomo and Squawan, Chen Quen Mentomi Kakakanak Chasium, Yonsio So Manman to Squalls to Seats, Yonsio Manman Squawan, Yonsio Manman Equatal Chet, CII Chet to Squalls to Seats Squalwan. Asking you, Creator, to watch over and protect each and every one of your children gathered here today and all of their families and friends with their Squalwin, mental, emotional, physical, spiritual well-being and health. Asking you, Creator, to help this day in the workshop and gathering that they're gathered for to be yet one halt top excellent work where they in Chomot and Squalwin and have one heart and one mind, and to be able to share ideas and all their different views to create solutions for the present and future generations. Asking you, Creator, to hear our prayers for all our family and friends who have serious illnesses or injuries and they're getting surgery or else treatments. For prayers, hear our prayers for their health, healing, and recovery. Asking you, Creator, to hear our prayers for all our family and friends who may have traumas and have battled with alcohol and drugs, especially during this time of the opioid fentanyl crisis, and all the young people that are leaving us, that we pray that they actually find, and those incarcerated because of those battles, that they find that healing path to recovery and become survivors, to maybe share their stories to help others not walk that dark path. Asking you, Creator, to hear our prayers for their families who worry about them, and also, Creator, to hear our prayers for all the families and friends who have lost loved ones in the last while, who have AM squalling strong feelings of sorrow in the heart, to know that that pain changes eventually, to remember their loved ones with happiness and joy of the memories that were made, and that they worry about us and send us signs. I had heard that dragonflies have two sets of wings because they carry angels on their backs, or ladybugs, they say, are angels, and that when they fly around you or if the ladybug lands on you, it's a kiss from your loved ones to lift your spirit. So watch for the signs of those or hummingbirds, butterflies, eagles, raven, something you don't ordinarily see when you're in a low mood. Know that it's your ancestors and loved ones lifting your spirit, because then you start smiling and then you tell other people and they start smiling. That's them helping you spiritually. So always remember our old ways and the power of prayer to Creator. So Creator, I ask you again, let today's meeting be at one half dates up. Let's today's meeting be an excellent work in building a new legend. Tama Quetzi Snachum, those are my words. Chen Quinn Mintomi, I'm grateful and thankful that you let me start your day and hopefully set you on a good path and be focused on what you've come together for. So.
Oishka, Sequoia, thank you.
Thank you very much, Sequoia. And thank you for starting us off the right way today. That really is helpful and it grounds us for the day. And we really look forward to you rejoining us again this afternoon.
Okay, then. Thank you
and I hope you have a wonderful day. The next item that you're moving on to in your busy schedule.
Thank you so much. And you take care. Wachayapyo, you all take care until I see you later.
Bye, Sequoia. Thank you.
So thank you very much to everyone that's here today. And I wanted to welcome you everyone to our first virtual Research Ethics Symposium. As some of you will know, this symposium replaces 3 conference or educational opportunities that we were planned for this year prior to the pandemic. We are pleased to be able to provide the symposium in a virtual format, and registration has demonstrated that this format has opened the event to a larger number of attendees. So it's really been a bit of a blessing. About housekeeping, just to get us started. Normally, I would start this off by telling everybody where to find a cup of coffee and where the bathrooms are, but I think you all know that. So the housekeeping information, we're just going to focus on the interaction using Zoom. So we really want everyone to make use of the Zoom chat. But we are going to put your microphones on on mute during the presentations themselves. And then if you're going to use the Zoom chat in order to ask any questions, we ask you just to preface any questions with the word question, because while the presentations are going on, our lovely assistants, Paula and Aoife, are going to work through the Zoom chat and make sure that myself as a moderator will know what the questions are that came up during the session. And if you want to instead ask questions by raising your hand, there's some instructions on the screen to show you how to do that using Zoom. So if you're on a PC, you use the icon labeled participants at the bottom of your screen. And then there's a button labeled raise hand that'll come up on the right hand side, and it's a blue colored. And then if you're using a mobile device, tap raise hand on the bottom left-hand corner of your screen, and the hand icon will turn blue, and the text below it will switch to say lower hand while your hand is raised. So we just wanted to give you some tips to set you off well. And then I'm going to move on to getting us started on this very first session. So to get us started following the lovely grounding, this session of the symposium will discuss some of the unintended consequences of the pandemic in BC. I am pleased to welcome our first speaker, Jane Buxton. Jane is professor in School of Population and Public Health and works half-time at the BC Centre for Disease Control. Over the past 10 years, she has supervised over 100 postgraduate students. At BC Centre for Disease Control, Jane is a physician epidemiologist and harm reduction lead. She co-chairs the BC Harm Reduction Committee, and in 2011 developed the Drug Overdose and Alert Partnership. In 2012, she led the introduction of the BC Take Home Naloxone program. Thank you very much, Jane, for all that you are doing and for being here today. I'm going to now turn it over to you and let you lead us off in your presentation.
There we go. So thank you for inviting me. I am delighted to be here, and I'm going to talk today about the colliding public health emergencies and the role of people with lived and living experience as experts and as researchers. So I gratefully acknowledge that I live and work on the ancestral, traditional and unceded territories of the Coast Salish people. I also have to add that as we have an election coming up in a couple of days, I'm not able to discuss the policy and the program aspects that emerge from the research. So I'm going to focus mainly on the research. Next slide, please. So I have no conflicts to declare. I'm UBC faculty. I'm employed half-time at the BC Centre for Disease Control. I hold grants from CIHR, Michael Smith, Health Canada, and the Ministry of Health, and I'm co-investigator. I have no industry funding at all. Next slide, please. So
I think I'm having more luck with mine.
So what I'd like to get across today is that peers or people with lived and living experience are underestimated and undervalued. Their real life knowledge is immense, and the undervalue comes in what they are able to do and also how they are paid. In all their research roles and provider roles, they face stigma and discrimination. And they are committed, creative and adaptable, and fabulous educators. I learn far more from people with lived experience than they do from me. And they always help to keep the research team grounded and real, and help to identify what the priorities are. And they're also key to effective knowledge translation initiatives. Next slide, please. This slide is really just to get across, I think what we hear often now is patients as partners and patient-oriented research. But I would suggest that in public health, in harm reduction, and as far as peer engagement goes, we've been doing this for a number of years. And certainly in BC, I've been involved in working with people with lived experience over the last 15 years in research and also in any policy and programming. Next slide, please. What we need to think about is that people with lived experience, it's a diversity of experiences that people have. One size doesn't fit all. And it varies where people are on their substance use journeys, whether they are actively using substances or whether they're in recovery. The substances used may differ as well, whether it's opioids, stimulants or alcohol. And also the mode of use, injection or smoking or oral. And of course, the different priorities, different challenges that youth or gender or ethnicity and also rural and urban regions. Next slide. Engagement of peer workers and peer researchers is recognised as best practice in harm reduction, both in programming and in research. They can identify nimble responses and solutions. I think many of us in academia may kind of have problems sometimes thinking outside of the box. We go back to, okay, let's develop a logic model, let's see what our outcomes are, how do we define our outputs, whereas people with lived experience are often very solution oriented, as they have been in their lives, and it helps us to move forward. People with lived experience can also create safe spaces. They build relationships and trust and connection with research participants who are, again, people with lived experience. And because they have that shared experience, it facilitates openness and willingness to share and not to feel judged. So I think, you know, we often will have work with people with lived experience as our facilitators in focus groups. And I think we get a much more open and natural response. Next slide, please. What I'm going to talk about today, I've been kind of working with peers or people with lived experience for many years, but I just want to share really 3 projects that we've been working on more recently, and then talk about how this has been affected by COVID, by the pandemic. The projects I'm going to talk about is Peer Engagement and Evaluation Project, and that was funded by Peter Wall. And we kind of worked on this one for quite some time, and it's almost like the foundation. It's created the foundation for our other projects. And the great thing is everybody that was involved, academics or people with lived experience, we were all peeps. So trying to get rid of that hierarchy, which so often happens when in an academic field or when we have the patients as partners. The second one is a national surveillance of illicit drug content, which is funded by Health Canada and the Substance Use and Addiction Programme. And the last one is a peer-to-peer, which is also a Health Canada funded. So I'm just going to talk a little bit about each of those. So next slide, please. So the Peer Engagement and Evaluation Project, PEEP, we started off by saying, what do we need to do? And we got together with our Harm Reduction Strategies and Services Committee and realised that there was a limited amount of engagement with people with lived experience at the health authority level. So we decided we would go around the province. We did 13 focus groups, which were led by our peer facilitators. And then we looked at the data, we analysed the qualitative data. And the photo you can see there is after we've had a session where we've printed out quotes on different colour paper. We've then discussed them, read them aloud, discussed them, decided where they fitted, and then validated the themes. Sometimes they got renamed and sometimes they got merged, and identified the priority quotes. So working with people with lived experience who the quotes were more meaningful to them than potentially the academic researchers. And then we developed best practice document and paying peer guidelines. And then out of that, we decided that we would take it back to what we call regional convergences. So taking it back to the community, both people with lived experience, but also to public health leaders and health authority staff and providers, and revise the guidelines. And I think a couple of the really poignant things that came out to me was, how empowering it was for the peer facilitators. And in fact, PEEP continues to this day, even though the research is over. They are a consultation body that we meet once or twice a week to actually put forward all our different programming and research and things. But 2 poignant comments. One was from a rural area where somebody said, you mean you actually care about what I think? You actually want me to tell you about my experiences? And then I think the second one that we heard a number of times is when we went back to the communities, was this feeling that, well, most people come in, they ask us questions, yes, they give us some money for our responses, but we never hear what happens and we don't see it again. And I think ethically we should really think about, it is our responsibility to take the findings back to the participants in a way that they can use the results and be aware of how we've used their words. Next slide, please. And these are just some of the documents, the engagement principles and practices, the paying peers guide, and then the language matters. I think we're all aware of the stigma that comes along with the language that people use. And it can be very dehumanizing. We should be treating everybody with respect, regardless of where they're coming from, and treat them in a supportive and non-judgmental manner. And I think having a very simple 4 guidelines, use people first language, use language that reflects the medical nature of substance use, making sure we're not using derogatory terms really is important. Next slide, please. So now to talk about the harm reduction client survey. So this is a survey that we used to do off the side of our desks for 4 years, in 2012 and 2015. And we managed to do this with, you know, minimal amount of funding. We were able to engage with MPH students who helped out and did the analysis or helped in the process. But what we really learned, and as the overdose crisis emerged, was the fact that what people thought they used and were reporting using didn't really reflect what was in the illicit substances on the street and what was actually being used. So in 2018, we got funding from Health Canada to do a surveillance and urinalysis. So asking questions, but also taking a urine sample, which would tell us what people had consumed in the last 3 days. People with lived experience helped to facilitate, they helped to tell us, we discuss what are the issues that are emerging, and they help with wording the questions in a way in which would be understandable to the folks that we are surveying. And the surveys are done at harm reduction distribution sites across the province. We have fabulous information from Vancouver and from Victoria in some of the cohort studies and some of the studies that go on around, but not really across the province. And through this, we've managed to identify and publish on, you know, whether people know they're using fentanyl. We've often heard that fentanyl is contaminating and people are unsuspectingly using it. What we know is people who use our harm reduction distribution sites know exactly, the majority know that there is fentanyl in their substances. Why people use alone, and this is really important, especially now when we have COVID, that we're telling people to distance, that we're seeing a reduced amount of use of overdose prevention sites. What we found when we asked people why they were using alone, most of them, it wasn't through stigma, it was actually for comfort and convenience. Some of the overdose prevention sites were busy, they ended up having to share substances with friends if they were using together, and you know, they could use alone, have music playing, they could be on their bed. It was comfort and convenience as the main reason. We also looked at who owned a naloxone kit and who we needed to target. One thing that we've learned very recently is that more people smoke opioids than inject, and that's really helped us to move on and do some other, apply for funding to do some other studies. We also realized that methamphetamine use has increased. 72% of our folks that answered the survey in 2019 said they use methamphetamine, and the majority were actually using opioids as well. So that's led us to do another study, and we've got funding to try and work out why. What is it about why people use together, or in what order, and what are the reasons they do, so that we can help our messaging on harm reduction. I think one thing I wanted to bring out here is that in the past, when we've worked with people with lived experience, we've often done lectures and training and discussions around research. And for this particular project, 7.5 out of 8 of our researchers, who are people with lived experience, have completed the TCPS2, and they have their certificates and they are proud of it. Next slide, please. So this is the next project. Again, this is ongoing, and it's a peer-to-peer project. And what we realized was that people who use substances that were working in overdose response environments were really quite stressed, didn't feel that they had sufficient support. So we wanted to find out what would help and what they really needed. So it's peer-led to identify interventions and then to evaluate those interventions. And we are working with 2 organisations, Solid in Victoria and Rain City at their sites in Vancouver, Maple Ridge and Coquitlam. Next slide, please. And we did 8 peer-led focus groups, and we identified some of the issues. And work conditions are stressful. People felt underpaid and undervalued. Also, they're always on call. For those of us that work in this area, many of us have a home we can go to and relax, and we can have a glass of wine and watch TV. But that's not the reality of many of the researchers who go home, but they're in that community and they're seen as somebody who can respond. So they're always on call. Lack of respect and recognition for their work by other people they work with, but also by other professionals. And of course, it's compounded by grief and trauma and loss. The quote here, "I look forward to going to work because I feel like I'm doing something good out there." So it's also empowering, and people get a sense of accomplishment. So out of this, we developed the ROSE model, and the artwork you can see is by one of our peers, and the ROSE stands for Recognition, Organizational Support, Skill Development for Everyone. And we have a little video which kind of puts those into perspective, which is on the next slide or will be shown to us. Thank you, Aoife.
R stands for recognition of peer work. Experiential workers feel they do not get the respect they deserve from other professionals and experience community-level stigma. There are multiple interventions under the R arm of the model, including meet and greet events with other professionals, such as police, housing agencies, and paramedics, to facilitate relationship building. We also created a video called #PeerLife, which features a day in the life of a peer. We also created photo ID and business cards to professionalize the role of experiential workers. O stands for organizational support. Many experiential workers highlighted a lack of clarity around their roles and a lack of support in the workplace. We created documents to formalize the role, including job descriptions, recommended pay, a job contract, and an orientation checklist for new workers. A peer debriefing program was also implemented at one of the pilot sites. S stands for skill development. Experiential workers identified several skills that they would like to develop further, including mental health awareness, first aid and CPR, overdose response in light of COVID-19, self-defense, conflict de-escalation, and pulse oximetry. The E is to emphasize that the initiative and all of the resources developed are for everyone. Our team is committed to making all resources publicly available.
Great, thank you. So we can go back to the next slide. That would be great. Thank you. So what we learned from the focus groups and from working with people with lived experience is that the work conditions are really stressful and emotionally taxing. They suffer, people get a lot of stigma from colleagues and professionals and feeling powerless. Their everyday lives, as I mentioned, they're always on call, and the trauma. And then we looked at the coping mechanisms and the supports needed. And some of those coping mechanisms are using substances. And because people are often felt that they are looked up to in their role as a peer, as an overdose responder, sometimes they would actually not use in a safe environment, but would go home and use. And that really concerned us. So trying to work with that and the supports needed we just discussed. Peers are resilient. They're not vulnerable. And one of my, colleagues will always tell me that, we survive in circumstances that you just would not believe. We are resourceful, we are resilient. And we hear a lot about burnout. And I think the burnout, to me, kind of puts the onus on the individual. It's almost like blaming them for not taking care of themselves. And I would suggest that, a lot of the burnout is more at a systems and a structural level that we need to address. Next slide, please. So we were doing all this work, and then COVID hit. And you can see the public health emergency about the overdoses was declared back in 2016. Unfortunately, the overdose deaths increased. And of course, we have to remember that every death is a person, it's not just a number. These are people with loved ones. And, you know, we actually thought we were seeing a decline in 2019. It was still totally unacceptable. Usually we were seeing back in 2013, 14, about 20 overdose deaths per month, and you can see how it's gone up. COVID happened, and there was a huge increase in the numbers of deaths occurring. We went above 175 on 3 consecutive months. It did come down in August, and it is a little bit lower in the results September, which was announced yesterday. So next slide, please. If we look at the things that we said we wanted to do with in the peer-to-peer project, some of it has had to be on hold. The meet and greet with other professionals, team building days, and some of the courses that we had put on have been put on hold for the moment. But we are still working, and we meet regularly, weekly with the people with lived experience. Next slide. So really, I just wanted to talk about why are we seeing that increase? I mean, I think the physical distancing, people are feeling isolated, increasing using alone, reduced access to services, including drop-in and overdose prevention sites. Drugs are more toxic. There's travel restrictions, and there's reduced international trade and precursors and things coming from abroad, which is where the substances were often coming from. And this really has increased the need for peer overdose responders. So their workload has increased whilst all this was happening, with increased on-site peer witnessing and mobile services. Next slide. So this just shows you that the number of visits to overdose prevention sites and supervised consumption sites plummeted. It was actually coming down in the end of 2019, but you can see how it fell dramatically, and then how it's actually rebounding, but very, very slightly. Next slide, please. So with the overdose crisis, because we were meeting with people with lived experience on a regular basis with our projects, we realized that we were told that they needed, that the information that was out there was really not accessible to them. So we developed resources which were user-friendly, with input from people with lived experience, and you can see the everyday superhero there who's carrying naloxone. So all those kind of things. So working with the peers who told us what they needed, there was very confusing messages. The other thing, next slide please, the other thing we were hearing was that in our, when we looked at what drugs there were in the drug checking in the corridors, that we were seeing increasing benzodiazepines. So we had the peer-to-peer was happening at the time, and we wanted to make sure that we could help them respond in a way that addressed the issue with the benzos. So we distributed oximeters, and then we evaluated them. Next slide, please. So oximeters measure people's oxygen levels, and what we found was that it really helped people to be more objective in when they were responding. It told them when they needed perhaps to give breaths, and if they weren't giving breaths, then that obviously was reducing the risk of transmission of COVID-19. But it also gave people confidence. They felt that they had leadership, they were more professional, they could tell the ambulance when it arrived, what the level of the oxygen was, and it really was a very positive experience that came from that. Next slide, please. So I think what I've hoped to get across is that applied public health research, we use it to identify, explore, and respond to emerging issues, that people with lived experience are the ones that can really tell us what's important. We have an ongoing survey, so we can add questions to it. We've actually, one of our proposals we've just had funded is looking at using these oximeters in overdose prevention sites that are where people inhale. So again, it gives that distance so people, responders don't have to be inhaling the smoke at the time. And it really informs what we do. I think the importance of knowledge translation can't be overemphasized. Next slide, please. And we have developed some modules which are, they're little scenarios based on things that we heard. And this is one that is talking about stigma in the workplace and inequities. And it's like a 2-minute video, and then there's a facilitator's guide. So that's one that happens throughout. And I'm just going to finish up on the next slide. We have a video, and what we'd like to have is just, we've got that short one, the peer life video. So this is the video that we created with people with lived experience because we wanted to use it to discuss when we were talking with professionals and take it to the police and the meet and greets. So we'll just listen to the first 1.5 minutes of the short version. And then that's the end of my, my talk.
Hey, baby girl. I love you. Hey, guys. Hey, good.
One-handed.
Yeah. My name is Denise Edwards, and I'm known as Grandma Coquitlam, Ma, Mom, or Grandma. I answer to all of them, and I'm proud to be a peer worker.
I became a peer worker just over 3 years ago. As a person, you know, that spent his life in prison and spent his life doing drugs, you know, I thought, well, what am I going to do for employment? Well, no one's going to hire me. And then this guy wants to hire me. And I said, well, what do you do? He said, we work with street people. And I thought, well, that's something I really know.
I'm a functioning drug addict, and I look around and I see my friends and even some of my family that have passed away and have overdosed and have caught different diseases, and I want to help. I've saved 72 lives up to date. I haven't lost one yet, and I don't plan on it.
Saving lives, you know, when someone comes out of it, you just feel elated, eh? It's like, whew, did a good job, eh? Shake the guy's hand, he smiles at you, eh? Or sometimes they'll just insult you. Yeah, so that cost 30 bucks, you just blew 30 bucks off me. But I know that's him in that moment, because I know next day he'll come over and thank me for, you know, for helping him out, eh? And that's the best. Someone just says thank you.
Thanks, we can stop there. Great, so my last slide was just a thank you, and obviously I'm thanking all the people that I work with, the peers especially, but all the rest of the team as well. So thank you for your attention.
Thank you very much, Jane. That was really moving and very informative. I have a question that's come from your colleague, Paul Hasselbeck. And I'm just going to read it out for you. Working with peers and persons with lived experience is a rewarding experience in and of itself, and has been a learning journey for all that has the potential to benefit other research work. The focus is on research ethics specifically. What fundamental learnings from research involving persons with lived experience, I lost track there, should be applied to any research involving other populations, such as persons with specific illnesses, in terms of engaging participants in research design, ethics approval, analysis, knowledge translation, and dissemination of findings?
Yeah, I mean, I think it's also in what we apply for funding for. You know, what are the priorities? If we're interested in a particular disease or working with certain folks, we have to hear their voices. I mean, their voices are the important. They're why we're doing the research. And I think so often, sometimes we think about what our priorities are, and sometimes it's a challenge when we're looking for funding opportunities to do research to try and fit our square peg in the round hole that's coming out from the CIHR or whoever. I mean, I'm really fortunate in some ways working in this area that there have been, especially recently, a lot of opportunities. But I think it is so, so important. And I think not just to engage people and making sure that you're listening to those voices, they prioritize what direction you're going in. And I've learned so much. In the past, when we were doing participatory research, it was quite difficult to get funding because you didn't quite know where you were going, because it was participatory and you had to kind of make things up. I think now the granting, it's a bit different. And I think also with ethics, I think ethics has come, it's really helpful to work with ethics to explain why we're doing things. I remember the first time doing a project where it was around alcohol substitution, and having a group who didn't want to have a consent form. They wanted to develop their, you know, their creed, and they wanted that, and there was difficulty getting that through initially, and now it's kind of accepted. So I think it's progress. I think, and as I mentioned before, and I'm passionate about, is taking our findings back and checking them, not just if it's a qualitative and doing the member checking and validating it, but, you know, when you've got your numbers, taking it back and saying, okay, we found this, what can we do about it that's going to make sense? Because we can put in as many programs as we like, but if it's not acceptable and people don't want to take them up, then it's pointless.
Very good point. Thank you, Jane. Do we have any other questions that for Jane at this time, or shall we? Anybody with a raised hand? I'm quickly scanning the 155 people in the room. I know we had a comment from Gwen. Gwen, would you like to make that comment, or make sure that Jane hears it? Okay, you can unmute yourself, Gwen, or we can unmute you.
Okay, thank you very much. Yes, Gwen Campbell MacArthur here, on the patient council and the board of directors for the Academic Health and Research Network. I just wanted to make a comment as a former mental health, mental wellness and addictions professional, that often, even though we worked and offered advocacy and support for people who were suffering addictions, I often faced a stigmatization myself from other professionals and the general public, because I was on the street and I was very visible in the community. I was often seen as colluding with people that I served, that I was actually supporting the use of substances, and that because I did work in corrections and there were people that had committed serious crimes, that I actually supported that lifestyle, and I actually supported people that are living on the street. And so in terms of the moral distress, and you talked about people that are on, you know, called 24/7 and those kinds of things, that was really, really difficult for me, because often I couldn't express myself as to my own values and my own ideas around why I did the work I did. And I didn't collude with people, and I didn't commit the crimes, and I didn't use the substances. So that in itself for me, and that's why I'm really glad, Jane, that you're doing this kind of work, and thank you very much for, this kind of conference or the Zoom. I really appreciate being able to participate.
And I think stigma by association is huge. And, you know, even within colleagues that I worked with, people would say, oh, you're doing harm reduction. But since the overdose crisis, and I think that really, you know, it's so distressing and unfortunate, but the profile has increased, and the need to do something about it. And I think we're seeing, you know, the Mum Stop the Harm and parent groups coming out. We're getting perspectives from people other than in the downtown east side, and people, and I think that's what amazed me yesterday, was when you saw the announcement of the numbers of overdose deaths that occurred in the last month, was that the media still showed downtown east side, grungy. You know, this is happening all over the province. It's not just in one region, and I think we have to get beyond that. But I really hear you, and I'm, you know, sorry you were obviously distressed by that, and it is difficult. And I find working with other people in harm reduction, it's my self-help group, because, you know, working with like-minded people and also working with people with lived experience really keeps you going. You have to be passionate, and people do not always survive in this area and perhaps have to take a sidestep, and it depends what else is going on in your life. But I really appreciate that comment.
Thank you. We're going to take one more question that we have, and then we're going to save the other ones that we've received for posing during the general discussion after the next speaker, if that's okay. Hannah, I think I'm going to save yours for after the next speaker. I'm going to ask the one, which resources, I'm sorry, I'm trying to find out who asked this. Zoe asked this question. Which resources, tools, or experiences have you found to be the most effective for convincing other academics and professionals that expertise is the purview of many others out there, not just papered experts?
Well, certainly, when we publish anything, we have people with lived experience on our publications because they provide so much knowledge as well. So it's always interesting to say who is the papered experts, because we do have peers on our publications, and they do meet all the criteria. So I think that's important. What I find is, and it's strange doing this presentation of why I kind of had that last video, is that usually it's presenting with people with lived experience, because their message is so much stronger than mine, and they can articulate things in a way that I can't, because they are living it. So I do find it's important to have those voices at conferences where it's possible. And you know, it's really hard when you have a 20-minute or 25-minute presentation, but I think it's the most effective thing is by people actually listening to the voices and listening to the experience and the expertise that people with lived experience of whatever can actually make people think in a different way.
Thank you, Jane. And again, Jane's going to be with us until the end of the session, so we'll have time for some more of these questions that are being posed. But right now, I'm going to move us on to our next speaker, Dr. Julia Smith. And Julia obtained her PhD in Peace Studies from the University of Bradford, where she was a Rotary World Peace Fellow. Currently, Julia is a University Research Associate in the Faculty of Health Sciences at Simon Fraser University. In addition to currently co-leading the Gender and COVID-19 project, she plays a lead role in research on the political economy of the tobacco industry and Indigenous peoples' health. Her research interests center around the social, political, and commercial determinants of health, global health governance, gender-based analysis, sexual and reproductive health, community development, human rights, participatory methods, and feminist theory. She has worked with health and development projects in North America, Europe, and Africa, and frequently works in consultation with government actors and multilateral organizations. I just want to say thank you, Julia, for taking the time to join us today. And now I'm going to turn it over to you, and we're going to see if we can help you share your slides.
Yes, let me try to start sharing here. Here we go. Get to the beginning. Wonderful. Thank you very much for that introduction. I assume you can all see it, and yeah, wonderful. So as I've been introduced, I'm in the Faculty of Health Sciences at Simon Fraser University, and I'm currently working on a project, not very creatively called the Gender and COVID Project. And this is turned into quite a big project. So we have research ongoing in 9 countries right now. And the project aims to identify the gendered effects of the response to COVID. And I'd like to highlight that word response. So many of us in this project are social scientists as well as health scientists. And we're very interested in how we respond to a crisis situation like this affects people differently, and especially in terms of, current inequities. And I think this is important to emphasize, because while the pandemic often seems like this overwhelming event that's out of our control, driven by this mysterious virus, how we respond to the pandemic is a choice. It's a policy choice. It's a political choice. And that's where we can have influence, or our government can have influence. And so the project is very policy focused, aimed at highlighting policy gaps and opportunities and providing tools and guidance to those in decision making. We started off with a grant from CIHR in February, and have brought on other partners. So in terms of the global work, we're working with the Bill and Melinda Gates Foundation. And here specifically in BC, we've also recently partnered with the BC Women's Health Foundation to do some specific work with healthcare workers. So before I get into more of the details, I just wanted to reiterate something that most of you are probably aware of, and that is why gender-based analysis. And that is because we know from past research that health crises have differential biological effects on our bodies. So if you think about the Zika outbreak in South America, you know, that particularly affected with female bodies because of its impact on reproductive health and the fact that unborn fetuses were the most affected. We've seen with other coronavirus outbreaks that men seem to be more susceptible to worse health outcomes, and there may be some biological reasons for that. However, we'll also really see different social and economic effects on people of different genders. So again, if you think about the Zika outbreak, not only did that primarily affect female bodies, but it has affected women in those communities that are affected in terms of having to give up work to take care for children with disabilities, losing other opportunities. It's affected family relationships. And so there's a lot of different socioeconomic impacts that are much more gendered. Where these impacts and effects are not considered, we do see crisis responses exacerbating inequities. And that's, kind of the thesis or the question behind this presentation and lots of our research. Is the response helping or hindering a movement towards greater gender inequality, and how can it be shifting towards a more transformative response? And with COVID, definitely we are seeing that the health and socioeconomic effects of the response are very much gendered because of, demands around physical distancing, the closing of certain industries, and that's what I'll discuss in more detail from our findings so far. This has been very much a project that has developed very rapidly and in an unplanned fashion because the pandemic has been relatively unpredictable and rapid. So as I said, we started off with a project that included 4 case studies submitted, and that was based on a proposal we wrote in February. By the time we got that funding, so much had changed, and then we had other partners come on board. And so, I really describe this project still as building the ship while sailing. And of course, the challenge here is not only are we sailing, but we're sailing through very stormy seas. And that creates all sorts of challenges in terms of planning, in terms of, many of us on the team are, also dealing with challenges related to just living in a pandemic and so on. So we've got a lot of different sort of methods, some being implemented in different contexts. So here in Canada, I've conducted about 25 interviews with people who were experiencing different effects of the pandemic in May and June. So I spoke to parents, healthcare workers, other frontline workers, newcomers, and others. We're also doing key informative interviews with decision makers, virtual policy or virtual focus groups, and different kind of combinations. I have to give a shout out to the Office of Research Ethics at SFU because I don't actually know how many ethics applications and amendments I've submitted since February as this project has evolved. But it's definitely a personal record, and I feel like might be a university record, but I have constantly been needing their help and support, and they've been so responsive. So I just really wanted to recognize how great they've been, recognizing the urgency of the research and also the fact that our plans have had to change multiple times. So the actual results I'm going to talk about in a moment are going to be about what I found here in BC, but I wanted to highlight here kind of one of the key findings, and that is that you know, COVID is very much a global health crisis, but as we're starting to do this research across contexts in very different countries, such as, you know, Canada, Hong Kong, China, the UK, we're finding very similar themes, which is suggesting to us that global health is very much, or that this is a global health crisis, but it's also very much a global gender crisis. And around the world, we're seeing very similar effects on different people. Particularly, our research so far has, you know, really exposed these effects on people who identify as women, so women and trans women. And I think that might be more to do with the scope of the research so far. And those effects we're seeing are really around financial discrimination, health insecurity risk, a crisis in care. And I'm going to describe these more. And then some intersecting factors. And while we are focused on gender inequities, we recognize that gender intersects with many different other identities and social and economic sort of groups. So the themes, again, that we're kind of pointing out as intersecting here, what we're finding is newcomer status. And again, this is around the world. So in all of our case studies, we're really finding that people who are experiencing some of the worst financial, you know, effects, that are on the front lines of the response, are often newcomer women and other groups. Ability, so when it comes to the changes in care work and how that's happened, that's definitely affected different people, and how, you know, their levels of ability, people living with disabilities have been disproportionately affected. Of course, socioeconomic status, one of my colleagues, you know, always says, you know, wealth is the best PPE in the case of COVID. And if you don't have that, you know, you have less access to being able to protect yourself. And so on. So, and age, of course, which I think is something that sometimes is neglected in our intersectional analysis. But if you look at the statistics from Canada, for example, if you look at the mortality statistics, the worst health outcomes, it is older women. And I think that's something to highlight. So I just wanted to give you that kind of global overview before I go into the specific findings. So as I mentioned, I conducted 26 interviews with people during that first phase of COVID in May and June, when most of us were still, you know, really strictly physically distancing, working from home if we could or not working. Kids were out of school or daycare. And so what I'm sharing now is some of the findings from those interviews. And the first, you know, really relates on this theme of financial discrimination and the fact that this is exacerbating a pre-existing inequity in terms of women in the Canadian workforce, and the fact that they're more likely to be in part-time or precarious work. And then, as I noted, newcomers are also more likely to be employed in part-time and precarious work. And so when you kind of combine that together, many of the newcomer women I talked to had lost work. This quote here comes from a woman who had come to Canada quite recently. So because of that, she hadn't been working. She didn't qualify for CERB, but she had lost work. She had just started working just before the pandemic hit. And then she had lost that job and has a part-time employment, but of course that did not allow for sick leave, did not allow paid benefits, it offered no securities. And this was someone who's very much working on the front lines as a healthcare worker. So that was definitely a key theme, is, you know, a lot of the precarious work that many women fill or are forced into made them more vulnerable economically when the pandemic hit. Oops, why am I not going? There you go. And this discrimination did, you know, affect people of all different socioeconomic groups. So I had the opportunity to join focus groups that were coordinated by some physicians in the Vancouver Coastal Health Authority from the Equity, Diversity, Inclusion Committee, and they were bringing together women physicians to talk about their experiences during COVID. And one theme again that emerged here was about the financial differences. So a question that was asked during the focus group was, have women physicians had a different experience than men physicians? And one of the differences that women physicians noted was they felt that they were more financially impacted. And part of that was because of the type of work that many women physicians did, which meant that they weren't necessarily able to always do virtual consultations. They were more on the front lines in clinics as family doctors as opposed to in management roles that could then work, you know, from a distance. So they definitely, you know, there's one quote here of a physician whose income really declined. The other theme that emerged was that they felt there was a disproportionate financial impact because of them having to give up work to take care of their children, which was an expectation placed on them as mothers that they felt was not placed on father physicians. And you know, there's lots of discussion about where this expectation came from and how much of it is self-placed and how much of it comes from the broader culture. But you know, they talked very much about how there was pandemic pay. So if they were exposed to COVID and were unable to work, they could access pandemic pay. But if their kids couldn't go to school because of COVID, they would have to give up shifts and not work to take care of the kids. And so that was, you know, an impact that was felt to be different for women than for men. And that relates to the other theme that's really emerged. I'm sure many of you have heard and probably had personal discussions and experience of this. And this is the crisis in care that's emerged with COVID. With kids not going to school, with kids not in daycare, and even now with uncertainties around school and childcare and, you know, sporadic closures and that sort of thing. Again, you know, this quote comes from me speaking to a single mother, you know, who is, you know, just talking about the very basic struggle of not having a child in daycare. And it's not just that she had to, you know, she also had to give up her job and all that, but just getting basic necessities was a challenge. She spoke of, you know, having to go to the grocery store in this time of, you know, heightened fear and anxiety, being told not to bring children into the shop. But she had no choice because she couldn't leave her child with a neighbor as she used to. So she couldn't take her child to daycare. And this, you know, this really impacted her access to basic necessities. She talked about having to go to different shops to access toilet paper and hand sanitizer and all these sort of things. She spoke about having to stand in line with her kid who was impatient and then finally getting to the front of the line, and her, you know, her 4-year-old says, "Mommy, I've got to go poo," and she has to run off to find a bathroom and go home before she can go back. And I think, you know, these are the multiple impacts and stresses that are created by a lack of childcare that sometimes aren't fully impacted. I'd also just like to highlight this phrase that she said there about, you know, feeling like a very bad mom. And this is a phrase I heard over and over and over again in my interviews with mothers. Just that this guilt and this feeling of being judged and judging themselves, which I think is very concerning. And related to that, you know, was, you know, I think what's different about COVID compared to other crises is this dismantling of the support networks and the resilience strategies that many women often rely on. So when your child is sick, you can go to a friend or your next door neighbor, you know, or a relative to help you care for them. But in the context of COVID, we cannot do that in the same way. And so COVID has really dismantled the usual support and resilience structures that women use to mitigate the burden of care that is primarily borne by women. And it's worth noting that in Canada before COVID, women did 2 to 3 times more care work than men. With COVID, there's been some surveys done that do show that men have taken on more care work, but so have women, and women have taken on a disproportionate amount. So women are still doing quite a substantial more amount of the care work than men. The crisis in care, of course, also affects care workers. And I did a number of interviews with early childhood educators who were working during that time. So again, you know, if you think back to May, when everything was we were all very anxious, we had very little information about, you know, infections and how to protect ourselves. But there was childcare provided for essential workers. And the childcare educators, I spoke to them, were quite frustrated. They felt undervalued. And, you know, there's a lot of campaigns going on in the province around childcare and increasing the working conditions for childcare workers. And I think that's another kind of inequity that's been exacerbated, and about 99% of childcare educators in Canada are women, and these women spoke to me about, working on the front lines with children of people who were also working on the front lines and with absolutely no PPE because of needing to be able to interact with very small children, needing to give kids cuddles if they fall down. And so they were talking about how they feel very exposed, but very underappreciated. And again, I think the majority of childcare educators I spoke to, and I spoke to about 9, I think, told me nobody claps for us. And you remember at that time at 7 o'clock, we'd all go outside and clap for the healthcare workers. And the early childcare educators really felt they were not recognized in the same way, even though they were on the front line doing care work. And I think this speaks to the undervaluing of care work, whether it's the informal, unpaired care work that's done in the home or the formal care work that's done in the broader economy. So the other theme that's really emerged across case studies is unequal health and security risks. So though we do see very different sort of levels of COVID infection amongst genders in different cases. So in a number of countries, you see much higher levels of COVID actual infection amongst men. In other countries like Canada, it's actually higher amongst women. There are other sort of secondary health impacts of the epidemic and of the response. And one definitely relates to stress and anxiety. And again, across our case studies, we've seen quantitative surveys done that really show that women are experiencing much higher levels of stress and anxiety compared to men. And unfortunately, all of the surveys I've seen so far disaggregate only by men and women and do not include other non-binary genders, which is a huge gap that definitely needs to be filled. In our interviews, we interviewed women, men, and a couple non-binary people as well. And there's 25 interviews, so it's kind of hard to quantify, but we definitely saw that people who identify as women were talking a lot about stress and anxiety. Interestingly, many of the men I spoke to talked about their wives or their female partners' stress and anxiety as opposed to their own. And that might also relate to gender norms around what's, sort of acceptable to admit. But I definitely think this isn't, an unequal effect that can have very long-term consequences on women's well-being and career advancement and, other factors. This is a word cloud made from one of the focus groups with women physicians again. And as you can see that, there's a lot of talk about, words around stress, anxiety, insomnia. And lots of this again relates to that crisis in care around trying to balance their professional work and the care responsibilities at home. I'm sure many of you have also seen the news coverage and some of the reports around domestic violence and gender-based violence and COVID and how that increased very much during that period of initial lockdown and physical distancing, that as people were isolated in their homes, they were unable to flee violence. This was not something I have specifically asked about in the research. That is a whole other, there's a whole other ethics application I would have to do if we were going to look at this issue in depth. Interestingly, it did come up a couple of times, and I think it's what these sort of early results show is the drivers of that violence, the need for our policymakers and our responders to really unpack it more. So if you look at this quote, this woman is talking about, just kind of life under COVID, and she's saying, she's a single mother and that there was a past case of violence with her ex-partner. And because her childcare, her daycare is now closed, she now has to see that person. And that is very upsetting for her. So before they could do sort of a sharing of custody through the daycare center, she could drop off the child and then her ex could pick up the child. That is not possible because of childcare center closures. Not only that, family courts, if it was an emergency hearing, they were all delayed. And so the situation was delayed in being resolved. And so here you can see some of the ways these different effects interact to have, very serious impacts on people's lives. And to, as this woman says, it's making things worse. And it's not necessarily just COVID that's making things worse. It's closing the courts that's making things worse. It's closing childcare centers that's making things worse and contributing to this increased risk of violence for her. So kind of to conclude, I wanted to share this quote that was recently shared with me in a key informant interview as we're now moving into our policy analysis part of the project, because I thought this informant just really summed it up so beautifully. And she said, women are being conscripted into this. They're being drafted. But unlike soldiers in World War II who got paid pensions and training, women's sacrifice isn't acknowledged. It's just expected. And I think this really emphasizes that women are on the front lines of the COVID response, whether it's caring for children or providing health care. And they're doing that at great cost to themselves in different ways. I wanted to I knew Professor Buxton was going to be presenting before me, and her great research working with people who are directly affected and with bringing in lived experience. And so I wanted to kind of pick up on that theme and share some of the ideas that I heard from the people I spoke to. So a question that was asked in the interview is, what could be done to support you? What could be done better? What should the government be doing? And these was kind of some of the key ideas that emerged. And I think, they really show that these people that have lived some of the most dramatic effects of COVID really do have, very practical and excellent solutions for mitigating them, which I think we need to take on board, especially as we're now in the second wave. So, one idea was just having necessities available at a central location. So many of the moments asked, why cannot they not have supplies like toilet paper and hand sanitizer available at schools? They pointed out that, most of them lived in walking distance from schools, so they wouldn't need to take a bus or so on to get there. People spoke about, being quite willing to pay for things. It didn't have to be, they were reluctant to go to food banks or those sort of services for a whole bunch of different reasons. But if there was somewhere they could go to get what they needed, where it was just one place and they knew for sure it was there, milk and eggs and all these things, how helpful that would be. And so I think, that's an excellent idea. Flexible temporary childcare options. So I did speak to some people who worked in an emergency sort of facility for adolescent moms, where even during COVID, adolescent parents could come and drop off kids for short times. And I think, that seemed like a really good option that should be more widely available. A lot of women spoke about, if there's somewhere I could just take my kid for an hour so I could catch my breath, or, trying to do job interviews over the phone with, 2 toddlers in the background and how impossible that was. So I think that, that's an, essential option. Pandemic pay for care providers. And I know the government is starting to address some sort of sick pay for care providers, but for people working on the front lines, there might need to be other options. Increased funding for nonprofit service providers, as the people providing services on the front lines, and also in order to encourage them to employ more people. A lot of women work in the nonprofit sector, a lot of non-binary people work in the nonprofit sector. And so this would be a way to create employment. Encourage multifamily bubbling. This is something that came up a couple times when people talked about the challenges of dealing with isolation, of managing childcare, and some solutions around having a couple families decide to bubble together in order to support each other. Prioritizing access to justice, legal proceedings. This includes immigration proceedings, and of course having more gender advocates in decision making. So our research is very much ongoing. We're just still in the first 6 months of it, I guess, or maybe a bit more now. We're focusing a lot on our policy analysis now at different levels, implementing the research in the different partner countries, our comparative as well as global level analysis. And we're starting a research project that will include virtual focus groups and interviews with women healthcare workers here in British Columbia. So thank you very much for your time. I welcome your feedback and questions.
Thank you very much, Julia. That was very topical. I had people private messaging me going, thank you, they're grateful for being here and being able to hear this topic in particular. So now is the time when we would open it up to any specific questions that people might have for Julia. And then we will cycle back to a couple that we still had bubbling from Jane's talk earlier. So does anybody have anything any hands they would like to raise in order to ask questions specific to Julia? I'm looking through the screen and not seeing anybody. Oh, there's one. I have a question from Karen Maywald. What 3 countries or what was the study setting in this global study?
So in our global study, we are doing research obviously here in Canada. So we started out with the UK, Hong Kong, and China and Canada. And now we have also added Brazil, Bangladesh, Nigeria, Kenya, and the Democratic Republic of the Congo. So very diverse contexts, middle-income countries and low-income countries, as well as high-income countries. Yeah, it's quite interesting.
Yeah, that is good. I have another question from Paul Hasselback. We can always rely on him for great questions. Julia, many thanks for flagging the gender disparity that has been uncovered by COVID and similar disparities based on financial circumstances. And we can add ethnicity, indigeneity, recent immigration, ageism, etc. Can I inquire about your perspective about equitable financial supports for the research on the non-medical consequences of COVID and its interventions?
Oh, Terry, I didn't actually hear what you said, but I can see the question, so that's helpful. Okay. Sorry, you cut out there for a minute.
Oh, did I? Sorry about that.
Can I inquire about your perspective about equitable financial supports for the research on non-medical consequences of COVID and its interventions? So I'm just trying to the equitable financial. Sorry, I'm having trouble understanding. Do you mean the financial supports that are coming from the government, or?
Paul, if you are able to unmute yourself, would you like to unmute yourself and give her some context around this question?
I could. Thanks very much, Terry. Hopefully you can hear me, and I really did appreciate your focus on really uncovering what I think many of us are seeing as gender disparity component. But I guess what it really comes down to as a researcher, are you experiencing, in essence, some disparities in terms of access to funding to look at the issues associated with COVID? So much of the focus is on treatment, prevention, those sorts of things. And I'm really appreciating the other consequences that are out there. And what I'm wondering is, are you actually getting a chance to get the resources to do the work?
That's a great question. And I think, you know, as a social scientist working in the health space, this is something that I know many colleagues face, is that often this type of work and research is not valued in the same way as the biomedical research, or the research specifically on the health impacts and vaccines and that sort of thing. So we have been lucky, I guess. I think there is definitely not enough funding for this sort of research, especially on, you know, the intersections between, for example, economic disparities and health disparities. And so I think there's definitely a need for donors and people, you know, who are supporting this work to really look beyond the very direct health effects to the broader effects, and recognize that those have health impacts. So yeah, I think that's definitely a space that needs more funding and more recognition. It's often harder to, you know, meet some of the demands. You know, I'm sure we all have our stories about applying for CIHR funding and the challenges and limitations of those processes. But definitely in terms of doing qualitative research that doesn't that where the connection between, for example, financial disparities and health effects is sometimes more challenging to prove in a very empirical sense, but it's very real. You know, it's a challenge for sure. Yeah. Thank you.
I have another question here from Zoe. What kind of compensation did you offer participants? I recently reviewed an application to do with COVID and gender, and I felt as an overburdened working caregiver myself that compensation is key when asking for participation during this difficult time.
Yes. Okay. So it's a very good question. And I did offer the interviewees compensation, so they would get an e-gift card as a token of appreciation for their participation. The other thing that, you know, because we were doing these interviews in May and June, where it was, you know, a time when everybody was overburdened and so on, it was, our staffing was very much voluntary. So we were very, you know, I put out the call through social media, through some networks and so on for participants. But I really wanted to respect that only people who felt they had time, who wanted to share with me, would share. Like, I really didn't push or didn't do any sort of like aggressive recruitment, because I was very aware how overburdened people are. And yes, and then we would provide some compensation for sure.
Next question is from Muna. Thank you, Julia, for that amazing presentation. My question is regarding what you have learned so far from effects of COVID in women in humanitarian settings, i.e. conflict or post-conflict countries.
That's a great question. It is not one I have looked at in detail myself. The Gender and COVID project does host a Gender and COVID working group, and I'll put the link in the chat afterwards. And within that group, we have a subgroup on humanitarian conflict. And I think they've got a couple publications up already, but I have to admit, I have not actually looked into that myself.
Okay, thank you. Another question from Eugenie. In the 1990s, I worked in the immigrant and refugee NGO sector in Vancouver. I'm curious if your study included participants who work in this sector and their observations and leveraging of support funds for newcomer women and families.
My study did include some people that worked in that sector, and right now we're doing some of the kind of key informant policymaker interviews and talking to people from that sector. And I also interviewed a number of newcomers. I did not ask, I mean, in terms of the interviews that were done in May and June, we did not ask about leveraging of funds. So I don't know if I could speak to that. I could say I'm in the midst of analyzing some of these results, but I think, you know, what I saw in the interviews that were conducted with newcomers is how essential the services provided by many of the organizations that work in that space are to people's general well-being, like in terms of mental health well-being and community connections, and the disruption of those in May when, you know, people were not able to meet face-to-face, when everything went to Zoom, which is not the same and imposes all sorts of different barriers. Had very dramatic effects on people's well-being and health and access to services, and that a number of the people I spoke to who were really struggling financial were like some of the only places they were getting help were those services. So you really saw how essential they were.
This is a really rousing topic, so I've got more questions for you. Next question, Julia, a great presentation. This is from Minnie Downey from the support unit. Julia, a great presentation and work. You have identified some recommendations, opportunities. Do you plan or have you connected with policy or decision makers for KT or knowledge translation or potential implementation?
Yeah, great question. So we have produced a couple research briefs, which we have disseminated to policymakers at the national, provincial, and municipal level. I was also, very encouraged that there were people from the province that did reach out to us quite early in the process, and we've had numerous consultations with them The Burnaby Municipal Economic Task Force also asked directly for information, and I did a presentation to them. So we've had different engagements, also, at the global level as well with the WHO and UN Women. So we are trying to engage. This is always the challenge, right? It's like, okay, then you get the research, and then how do you get it out there to have impact? And we're still working on that. But it's for this project, it's always important for research, but in this context, it's incredibly important. I think one challenge that the whole team has really struggled with is, as academic researchers, we like to take our time and think and really be very deliberate in what we do. But like in May, I was getting calls. Okay, what do you have? What can you recommend? Da da da. And I was like, I don't know. I'm still doing the interviews. I need to analyze. I want to do my thematic analysis. And so it's been an interesting process in trying to, negotiate that tension of doing good research, but also getting results out as quickly as possible.
Yeah. Another question, Julia. You presented great info regarding the effects on women and children, but I was wondering, what does your research reveal regarding single-parent men?
That's a great question. I did not interview any single-parent men, and again, my sampling strategy is very voluntary in terms of putting out very broad calls and seeing who responded. So the 25 people I interviewed, 19 identified as women and 6 identified as men. All of the men I spoke to were in heterosexual partnerships. So I have not seen that. I mean, I think what I've seen in other studies that have looked kind of more the quantitative analysis is that single parent families are disproportionately affected in terms of lost hours of work. And I imagine that applies to both men and women single parent families. Most single parent families in Canada are headed by women. But, I think it's important to take the broader focus too, that single parent families, because of this crisis in care, are very disproportionately affected no matter who they are.
Next question. Thank you, Julia, as well. I got a lot from the presentation. I'm curious to know if you have come across any data that sheds light on how or if COVID-19 has impacted female academics and researchers when compared with their male counterparts. And this one's coming from Claire Mack.
Yeah, great question. The Faculty Association at SFU has just completed a survey on this. I don't think our results are quite public yet, but we are seeing, a differential impact on women academics. There's also been research done in the United Kingdom that shows that female academics are publishing less than they used to compared to men, and applying for less grants. So we're all, we are seeing a trend there that this burden of care, which is falling more on women, is, impeding women's academic women's publishing, applying for grants. Even if you look at the CAHR projects that were submitted over the last, since February, the applications that were submitted and the ones that were funded, there is a gender disparity there. And nobody's done the research to connect that directly to COVID, but we can make some assumptions.
Yeah. Thank you very much, Julia. I'm gonna, that's all the questions I have for you so far that have come in. They're coming in hot and fast. So I'm just gonna cycle back a little bit to other questions that came in after we heard from Jane. And one was from Hannah from SFU saying, how do you balance ethics creep with asking about knowledge translation plans and evaluating and approving said plans? So Hannah, would you like to unmute and give us a little bit more context behind this question?
Sure, I can definitely do that. I just have my heater on, so let me know if you can hear that going in the back.
That's good.
So we constantly have a voice in the back of our heads and from the research community about ethics creep and the ethics board reaching too far and maybe asking inappropriate questions. And I know that plays into how we do reviews, but at the same time, we want to have robust reviews and do deep ethics reviews and to make sure that we're asking the appropriate questions and we're hearing in patient-oriented research that knowledge translation plans are really, really important. So I just was looking for some advice or some guidance or recommendations about how far to ask about knowledge translation plans, and maybe how deep to dive into those, and then how to go about evaluating them.
Interesting question. I think often you're not quite sure what the knowledge translation is going to look like until it's done. It's hard to, say this is what we're going to do until you know what your findings are and perhaps how that's going to be. I personally think it's really important, but I have not had the situation. I mean, obviously, funding organizations will ask you how you're going to do this, and you always put forward, well, we'll do some plain language and we'll do some webinars and we'll get it out that way. But to me, those, and certainly in my field, those aren't the ways to actually reach the people that you need to reach. And again, I find working with people with lived experience that they're much more creative. They say, okay, we need to do this. This is how we're going to do it. It has been quite challenging because a lot of people, the folks who are using substances, they're very much interconnected and they like to connect with other people in similar situations, and it's hard. We can't really support that at the moment. And not everybody can do Zooms and things. So, one of the projects I've been involved in is, how taking it back to, to students, and then having people with lived experience being there to talk to what our findings were. But again, you're then using the folks who are most computer savvy that can use Zoom better than I can, as you saw earlier, so you're not necessarily getting everybody's voices when you are doing that KT piece. So I think it's difficult, but I do feel that we have to make it a commitment, and I've seen so many projects done where all that comes out of it is a publication and somebody's get some extra points for their career promotion, and that's just not acceptable in my view.
Yeah. So Hannah, I just want to dive a little bit deeper into that question and just ask, are you asking for that question as a bit of a discussion point amongst the other research ethics professionals that are here today as well? And would you like them to chip in on
all directions? It's a bit like, is it an ethics thing? Is it like, do we leave it alone? And as you said, it's a granting thing, so it's about the report back to the funder of the study. Do we just kind of, maybe when we're looking and evaluating, we look for that creativity coming from the peers? Or I know Sarah Bennett has mentioned before on the completion, they ask, how did the knowledge translation go, or how are your knowledge translation activities? So I think it's like a wide-reaching question.
Mm-hmm. I think so too. Sarah, would you like
to add? Sorry, just to add to that, I think by having people with lived experience on the research team, that's what really keeps you honest. And they say, well, what are we going to do with this? Where are we going to take it? So I think that's another important reason for having folks on the research team that you meet with, that keeps, as I said, keeps you honest.
Yeah. And is it really like up to the research ethics board to tell you whether or not this KT plan will work or should work, or how it should work? That's a good one to think about as well from the research ethics perspective of things, is that we need to know that it's going to happen, and that, like as you said, Jane, not just a publication that will advance somebody's CV, but also how it's going to happen, but not necessarily that is it up to research ethics to tell you how to do it. So Sarah, did you want to jump in? I saw you unmute and I put you under pressure by saying your name earlier, but.
I just wanted to say I appreciate the shout out, Hannah, and I think the accountability that you're talking about, Jane, is to the participants is really important as well, and your peer researchers, right? But I think in the context where I work now, the health authority, we have this extra impetus around checking in with people about their applied work. We get a lot of feedback from leaders saying, well, it's fine, but what the heck are they doing for my department, kind of thing. And I do believe, you know, natural research, so to say, should exist, but I think we do have an accountability in my institution to try and get that feedback. And so we just politely nudge them in terms of their study closures to tell us what happened. And that has actually been fine. And nobody's, you know, sometimes nothing's happened, and that's fine too. But we try to capture where that is and measure it a little bit in our larger research department. And that's been a good step for us.
I'm going to circle back to another question that came in while from Jane's talk, which is from Rita. The Peer Street approach is often effective when approached via 12-step program. Why isn't it supported by professionals in the system?
So by 12-step, you're meaning a sort of recovery abstinence, I'm assuming. And, you know, I think it is supported. I mean, what we know is that there isn't a one size that fits all as far as where people are on their journey and what is appropriate for them. I think it's a challenge, and one of the reasons that people are concerned about an abstinent-based and is the fact that if somebody has been using substances and especially opioids, and they use after a period of abstinence, they've lost their tolerance, and it's very, very dangerous. And we've had examples, and often in younger folks who have perhaps been in treatment but have not necessarily wanted to be there so much as pressures from family, and then have used again with tragic consequences. So from my perspective, it is a very legitimate treatment, the 12-step program. It doesn't suit everyone, and there are many who it can be more dangerous for. But I think we just need to have that whole spectrum of what is available for who. And, you know, with the 12-step program, we know that you have to break all connections with people who use substances, and sometimes that's meaning your family and your friends. And, you know, it's hard if you go back and see people again. So I don't know if that answers your question, or you have a second piece to that, or I've misunderstood what your question was about.
And I think you've done very well at answering it in generalities, but I'm approaching this as a patient partner perspective. And I do know a little bit about some of the public information programs around these 12-step programs. And often people go there to explore. And, you know, I mean, a good 12-step program will also suggest you to get outside help, but at least it offers a 24/7 support group to those people that are out there on the streets using it. I mean, and I come from a place too where in doing a public information presentation to a university of clinicians, and a lot of them didn't know it, didn't know what these 12-step programs were about. And I was also on an engagement that they didn't really know anything about the 12-step approach either. I mean, they understood a little bit about it, but they didn't understand it from, you know, how it can be beneficial for lots of people. So I thank you for this presentation, and you know, it just opens the can a little bit.
Yep, no, most definitely. And as I said, it does suit some, but we always have to, I mean, I think because I generally am working with people who are currently using, some who have gone through various programs and recovery at times, that somehow if they, I don't want to say slip, but if they start using again, they are no longer welcome at some of these programs. And I think that, you know, can cause people to hide use as well as being dangerous. So but I agree, it really does. It's the answer for some, and we just have to be open-minded and work out what suits who, when, and where. And I'm, you know, talking to people who use substances. Often they will want to go into a recovery, stop using, because their lives have got very chaotic. They're concerned around their safety and their ability to cope with things. But sometimes they come out with no intention of remaining abstinent, that it was really something that they needed to do at that time. So I think, you know, everybody's different. But I think having a mentor, having somebody that you're connected with, your sponsor, having a group that you meet with on a very regular basis works for some.
Thank you. Thank you very much, Jane. I have another question here from Lois. Jane, can you imagine, or do you have experience with the peers or those with lived experience being part of the ethics review as community members or maybe ad hoc experts?
That's yes, interesting question. I mean, and certainly with a lot of the projects that I'm involved in, we are peers, or we've found that in our last project, people don't like being called peers. They see that as a stigmatizing language. So we actually have experiential workers and experiential researchers is our latest vocabulary, but it always changes. But they are involved, and they are, as I said, take the TCPS too, but haven't had, I mean, and review all the documents and the question guide and what we're intending, but I've not known them to actually be on a review from an ethics perspective. But I think, totally, there's no reason why people shouldn't. They may not have an academic affiliation, but I think the insights that people with lived experience can bring is far greater. And there may be circumstances where, if we're doing a research project with people who have been in corrections, for example, then having that aspect around the ethics of asking certain questions and what needs to be done, I think, ad hoc would be a very reasonable way to go. And obviously not as a volunteer, but paying people for their expertise.
Very well said. Thank you. Do we have any other questions for our speakers? I'm quickly scanning to see if there's hands up. I don't see any, but please unmute yourself and shout out if you have a question and we haven't seen you.
I'll just give one shout out. I think from my perspective, and I think Julia mentioned it in hers, is thank goodness for that we can actually do amendments for research ethics, that, the research boards are very understanding when things change, when we have new evidence and we want to do something in addition, or, we found something that's different, and it's just, I'm just so grateful for being able to do that and not, have to resubmit everything from the beginning, and, the amendments as we expand some of our projects. I'm sure people can think, oh my goodness, not another amendment, but I think it's very well received from those of us that are working in this field in a constantly changing environment.
Yes, thank you. Thank you very much, Jane. Okay, well, I don't see any other questions coming up right now. So I just really want to say thank you very much to our guest speakers today, and for everybody that participated. For Sequoia, who joined us this morning and helped us ground this session and in the places that we live and work, and as well everybody that's been very interactive. In recognition of the speakers' time and commitment, the BC Academic Health Sciences Network will make a donation on behalf of our speakers to the BC Food Banks. Our next session will be this afternoon at 1:00 p.m. and we sent out an email this morning. I sent out an email, it's got my name on it, to all of the attendees that were registered with the 2 links for today, so that it is a different link for this afternoon. I want to say many thank yous to the organizing committee. As with all things with Research Ethics BC, this was a collaborative effort with volunteers from several of the organizations that we work with in Research Ethics BC. We will be sending out a feedback survey at the end of the event, which is tomorrow, to all the attendees, and we encourage you to please let us know what you'd like to see for future topics. We had a wealth of topics for this one with regards to the pandemic, but it would be really nice to hear what people want to talk about and have as a discussion now that we have such a huge platform in Zoom to be able to have larger meetings like this. So thank you, everyone. And that brings this meeting to a close. So we'll see you this afternoon.